Hello, everyone. My name is Emily Davis, and today I will be talking about mental health approaches for community integration. This is my occupational therapy capstone project at The Ohio State University in conjunction with Prototypes Pasadena, a program of HealthRate 360. I completed a scoping review according to PRISMA guidelines addressing the question, among adults 18 and over, what is the role of occupational therapy in supporting community reintegration? This is an important topic because the period following an inpatient hospitalization is a vulnerable time for patients. It is critical to coordinate care to reduce rates of relapse and readmission. I included studies published in English over the past 15 years. Studies needed to utilize an experimental design and incorporate interventions under the scope of occupational therapy. Included studies focused on adults 18 and up with serious mental illness, specifically schizophrenia, spectrum disorders, depression, bipolar disorder, and substance use disorders, or a past psychiatric hospitalization transitioning to community or outpatient care. Studies focused on inpatient or incarceration settings were excluded from this review. The literature search was conducted between July and August of 2024 using CINAHL, Medline, and APA PsycInfo. I've also included my PRISMA diagram, which guides us through the screening process. The initial search yielded 1,369 articles, 399 of which were duplicates, leaving 970 articles to screen. 873 were excluded based on title and abstract. 97 were full-text reviewed based on inclusion and exclusion criteria, resulting in 8 studies included in this review. The included studies varied in design, intervention, and outcome. The average sample size was 122 with a range of 15 to 324. Themes were explored using a concept map to identify key factors and ingredients of the diverse studies that support recovery and reintegration for this population. These included peer and social support, speaking to availability of peer support, family and friend networks, and group attendance and programming. The next is timeliness and structure of outpatient intervention, referring to being seen by an outpatient provider within 72 hours of discharge, having regular appointments, and multiple providers if needed. Lastly is multidimensionality of care, speaking to holistic care that addresses each occupational area. I completed my capstone project at Prototypes Pasadena, a community-based mental health organization. It serves individuals with severe mental illness, trauma, and substance use disorder. Services are billed through Medi-Cal and at no charge to the clients. Services included case management, clinical therapy, occupational therapy, substance use treatment, social and therapeutic groups, and food pharmacy services. The organization employs a trauma-informed, strength-based approach to prioritize individual care, dignity, and empowerment for their clients. I completed a facility analysis to assess knowledge, attitudes, and practices of providers supporting clients transitioning from an intensive mental health stay to services with prototypes. My key steps were collecting 18 surveys from OTs, case managers, and clinical therapists. I then conducted 6 interviews with 1 OT, 3 clinical therapists, and 2 case managers with clients actively hospitalized or who were serving clients that were hospitalized within the past few months. Lastly, I observed policy, procedure, and multidisciplined client care. The surveys revealed a number of challenges for providers. The surveys revealed a number of challenges for providers with a focus on a lack of training and knowledge on procedure and action steps, difficulty with communication between providers and in contacting the inpatient facility, and client difficulty with adjusting to life roles and receiving care in the outpatient setting. I was able to create resources and provide staff training in this area. This included a community transition workflow, which outlines clear steps for communication, discharge support, provider roles, and following an evidence-based timeline. The next resource is the Community Transition Safety Plan, which guides the conversation with clients about who their team is, when their appointments are, how to manage their medications, how to create supportive routines, and what the crisis resources are. Lastly, I provided recommendations on supporting group attendance and the value of introducing occupational therapy groups. I also created several occupational therapy specific resources, including a community transition interest checklist, which was designed to explore leisure activities and IADL challenges to guide OT intervention and support a meaningful daily routine following discharge from inpatient care. Advocacy for OT played a vital role in my work at Prototypes. I gave presentations for multiple departments to highlight occupational therapy's role in community-based mental health. I promoted the OT referral process and guided providers in assessing their clients fit for OT services. To further awareness, I designed palm cards for both providers and clients, offering accessible information on occupational therapy's benefits. Additionally, I represented occupational therapy at Prototype's Resource Fair, supporting individuals impacted by the Eaton fires. Beyond these larger initiatives, much of my advocacy occurred through direct consultation with case managers and clinical therapists, educating them on OT's scope, interventions, and the skills reinforced with clients to support their progress and engagement in meaningful activities. Participation in learning opportunities like mentor hours and group supervision allowed for opportunities to educate and advocate for OT services as well. I also had the opportunity to provide OT services to 6 to 8 clients with a history of or recent or active hospitalization. My capstone mentor was extremely supportive in building my caseload to inform my capstone project and provide an opportunity to educate and work alongside other providers in real time. I provided services in a variety of settings, including the office, client residences, substance treatment residential facilities, and in the community. I had the opportunity to tailor interventions to focus on community integration, adaptive coping, social and leisure engagement, and many other occupational areas enhanced by treatment in the community setting. I also had the opportunity to participate in the initiation of OT services for clients enrolled in the substance use disorder referred to as SUD at Prototype's treatment program. I completed SUD provider onboarding, which taught me more about harm reduction principles, the unique goals of the program, and evidence-based strategies for intervention. I attended SUD team meetings, shadowed individual and group treatment, created OT-based resources, and presented to the department on the role of OT. This was a meaningful step in my learning as many clients on my caseload had a dual diagnosis and benefited from a multifaceted approach. Lastly, an incredibly meaningful and beneficial element of my learning at Prototypes was their group supervision and mentorship model. So in addition to individual supervision with my mentor, I spent about 3 hours a week with other OT and Masters of Social Work students discussing clinical cases, interventions, challenges, and questions. These meetings were led by senior clinical therapists who encouraged reflective practices, learning through discussion, and interprofessional collaboration. It also provided a safe place to process the way our own experiences and emotions intersect with the work we do to support clients. This was an overwhelmingly positive experience that I hope to carry into future professional settings. To conclude, I'm very grateful for Prototypes for this incredible opportunity and for growing my love for community-based mental health occupational therapy. Thank you for listening.